Welcome to Accelerating Your Dental Practice, a podcast with free expert advice to accelerate your practice's efficiency, growth, and profit. Here's your hosts, dental management consultants and friends, Malika and Michelle.
Welcome to the Accelerate Your Dental Practice podcast. Today, we're going to talk about alternative hygiene scheduling models in light of the shortage of hygienists. I think you all know what I'm talking about. If you have been rethinking how your practice operates, then this episode is definitely for you. And I'm really excited to introduce today's guest, Rachel Wall of Inspired Hygiene. Rachel inspires dentists and their team to build highly productive hygiene departments by implementing systems for high quality periodontal care, enrolling restorative care through hygiene, letting go of the negative mindset and old beliefs, while managing the logistics of high performance hygiene department. Welcome, Rachel.
Thank you. I'm happy to be here.
Yes, welcome.
Thank you.
So I know this is a hot topic. A very, very hot topic. I hear about it probably 2 to 3 times a day from different clients. So I'm really excited to kind of kick off the new year with this topic. So can you explain to the listeners a little bit of what the alternative hygiene schedule modules are and what type of practices might consider them? Because I know it's not going to be something that every practice can do.
Sure. So I would say let's start with what the traditional model is, in my view, so that we're all starting from the same place. So the traditional model is one hygienist working out of one column, one operatory, and those patients are scheduled one after the other, in whatever, time frame that they have agreed to. I would say the most common time frame is 50 to 60 minutes per patient for recare patients. So that is our traditional model. I would say from there, everything else is alternative in my mind, right? Whether that is that there is a hygienist that is working out of one column, but they have the luxury of having a dental assistant that helps them maybe turn over the room. Maybe they can go and seat the patient in a consult room and kind of wrap up their conversation while the dental assistant turns over the room and gets that ready for them. The next level of that is one hygienist working out of 2 columns. Sometimes you might have a hygienist working out of 3 columns. That's unusual, but I have seen that done. And that is really where we get into the assisted hygiene conversation, because in order for a hygienist to effectively work out of 2 operatories, we say 2 columns of scheduling, in reality, they're working out of 2 operatories, is the best way to maximize that is for them to really be working as a team with a dental assistant. There are lots of different configurations of that. There could be 2 hygienists and 1 assistant working out of 3 operatories, where each hygienist is kind of, their patients are overlapping and the assistant is seeing the patients in that 3rd column. So there's a lot of different ways that this can be configured. But essentially anything in my mind and experience outside of that traditional one operatory seeing one patient after another would qualify as alternative.
So what would be the benefits of doing something like that?
Yeah, I think one of the immediate benefits right now is, there's some debate, I will say, in the industry. I mean, a lot of us don't think there's a debate, but there is a debate going on of whether or not there actually is a shortage of dental hygienists. I think for sure there's a shortage of dental hygiene hours. So there may be the same number of hygienists that are out there, but they're working in different ways. So perhaps, they're taking a non-clinical position. There are a lot of opportunities for clinical dental hygienists now than there were even 10 years ago to work in non-clinical roles. So, they may still be like me, I'm still a licensed dental hygienist, and they may do hygiene periodically, but that might not be their primary role. Or perhaps they are working fewer days or fewer hours than they were, let's say, 4 or 5 years ago. So the main benefit right now is to provide patients care when there are maybe not enough hygiene hours to support that typical traditional model of scheduling hygiene. Now, that's not to say that traditional model is necessarily the best way. It just is a way, and it's a way that we're all, I think, the most familiar with and the most comfortable with. I would say the other benefit of it is, with so much learning, so much technology, all the things we know now in dentistry and that we want to implement for our patients' benefit, it is getting harder and harder for dental team members. And I'm going to speak specifically about dental hygienists. It's getting harder and harder for them to implement all of those things within the confines of the traditional scheduling model. So the other benefit is that it enables the hygienist to work with a dental assistant, and maybe, it doesn't have to always just be one-to-one, but let's just talk about that model. Is they're working with a dental assistant who also has some capabilities to help implement some of those things that we know are now beneficial to patients. And so it's not just one person trying to cram everything into a 50 or 60-minute appointment. It's now two people that might be able to accomplish a lot more in the same amount of time. So I think that also brings us, Michelle and Malika, to the difference between assisted hygiene and accelerated hygiene.
Yeah.
Now, I think some people will say it's just a different word, and that is, you can use those words however you choose. But in my mind, accelerated is really when the time that the patient is in the chair is shortened in an effort to accelerate and increase the number of patients that one hygienist is seeing in that one column. So you're accelerating the speed at which you're doing things, and you're shortening the time so that you can see more patients in a shorter period of time. Whereas assisted hygiene, at least the way we teach it, is the patient is in the chair for the same amount of time that they would be in the chair if you were working in one operatory, but there's two providers that are helping provide that care. So that the hygienist may start one patient, and then that person may leave and go work with the next patient while the assistant wraps that up. So the patient is in the chair for the same amount of time. Sometimes they might even be in the chair for a little bit longer, depending on what they are receiving, the care that they're receiving. But there are two providers that are taking care of that patient.
So a question that as you're speaking, I can hear some of my doctors like in my ear saying, I'm paying two people to see this one patient and I barely get reimbursed by the PPOs enough to pay like the hygienist. So how do we kind of overcome that?
So there actually are seeing more patients throughout the day. They're just not shortening the patient time, if that makes sense. Mm-hmm. So that's how you make this a win from the practice and productivity standpoint, is that it allows that team to see more than the traditional 6 to 8 patients that would be seen in a typical day. So now they might see, instead of 8 patients, they might see 12 patients. And if they're in an advanced model, they might see 13 or 14 patients. So it depends on the type of care that the patients are receiving and the age of the patients and the amount of time that's scheduled. So it's not necessarily they have two, operatories and they're seeing the same number of patients. That would be lovely, right? But from a productivity standpoint, that doesn't typically add up. So yes, with the assisted hygiene model, it enables that team to see more patients than one hygienist would be able to see alone.
Yeah, and I think one of the things I want to add is what I actually just had this conversation with a client this morning was, I was like, I think you need to consider assisted hygiene because, he couldn't find a hygienist and one is retiring and he's got all these patients that need to get in and they're starting to complain that they can't get in. And he's also saying, I don't have as much treatment coming out of hygiene anymore because I'm not seeing enough hygiene patients.
Yes.
So, but what I was trying to explain to him was that the assisted hygiene will do two things. Yes, it might break you even, and it might not be like Michelle said, it might not give you that, profitable amount, but at least it feeds your treatment schedule and also gives your patients the care they need because now they're getting upset because they can't get in for 6 months.
Yep.
So it's a win-win situation in that sense.
Yeah. And I would say those are two of the low-hanging fruit benefits, right? Those are immediate benefits that can be achieved with assisted hygiene. I would say it absolutely can be a lot more productive because the other thing that it does is it opens up some breathing room for that assistant hygiene team to add services. So if you're doing the same services, but you're doing it in an assisted hygiene model, then you may profitability wise not come out very much ahead. But if you have the mindset that, hey, now that we have this opportunity, what else can we provide to our patients? Could we do, could we do same day sealants where the patient would have to come back? Could we expand our perio program because, I will tell you, as a hygienist and working with hygienists for 20 years, something happens in the hygiene mind when they can't get a patient in for scaling route planning for 4 or 5 months. They think, okay, well, even if I treatment plan this patient today, I can't even get them in. So I'm going to do the best I can today, and I'm going to check them the next time. And then that cycle continues for years unless somebody says time out, right? Either you start to see a lot of bloody prophies, you meet with a strategic advisor who says your perio percentage is 2%. Like there's some type of kind of, realization moment that something needs to change. That often continues for many years. Whereas if now all of a sudden we can get some blocks in place for scaling route planning, we can really work on our diagnosis systems and protocols, and that hygienist has someone to share that load, then all of a sudden we can be more productive. And we're also, by the way, providing a better, more comprehensive level of care for our patients. So there's a lot of things now from adjunctive services that can be presented to patients that are beneficial to patients and will improve their clinical outcomes that a lot of teams are just not even considering right now because of their schedule constraints.
So I know this is a huge topic and we could probably talk all day about it. I know that you have a digital learning product that
We do.
I know we're kind of missing the cutoff for this round of it, but I think you mentioned that it might be available later in the year as well.
Well, and what we can do, Michelle, too, is for your listeners in the show notes, you can provide, we have a different URL that can stay open longer. So if you have some listeners that want to check out our Assisted Hygiene Online Bootcamp, then they certainly can do that. So we can provide that to you and you can put that in the show notes. And then what they can do is also use your promo code. So we created a promo code for you all, AYDP 250, that'll also be in the show notes. And then you can take a look at that. So thank you for referencing that. What we have done is we've created this Assisted Hygiene Online Bootcamp. It is a self-paced, pre-recorded bootcamp that teams can go through together to really help them implement assisted hygiene in a way that is sustainable and successful and creates a win for the patients, the providers, and for the practice. And here's the thing is, I know one of the things we wanted to talk about was what type of practices would, use assisted hygiene. And really, I'm going this week to work with a periodontal practice that uses a form of assisted hygiene. So it can be used in any practice that has hygienists and dental assistants. And, as far as a dental hygiene assistant goes, that could be a very experienced assistant, or it could be somebody that's never worked in dental before, and the team could train that person. So there's a lot of opportunity there. And it could be something that a team uses as their everyday hygiene scheduling model, or it could also be something that they have in their back pocket and they're prepared and they test it out. And then if they have a hygienist that needs to go on extended leave, they could utilize that. If they have, a gap in their staffing where maybe they don't have the preferred number of hygiene hours that they like for a few months, they could use this. But I will tell you that a lot of hygienists, once they open their mind and they look at the model from doing it in a way that preserves the quality of care, a lot of times you really like it because they're not working by themselves. I mean, just think about how a dentist and a dental assistant work together. It works very well. The same can be true for the hygiene department. It's really not that different. Now, hygienists don't necessarily have as many procedures that they can do as dentists to warrant that dental assistant, but it can be a very, very positive experience. Myself, I developed this also with one of our coaches, Connie Simmons, and most of our coaches at Inspired Hygiene have worked assisted hygiene at one time or another, and we all really enjoyed it.
So I know that a lot of pediatric offices will use this method. And this is always like, I'm amazed at how fast and they bounce around from chair to chair in pedo. But how many chairs, operatories could one hygienist oversee realistically if the assistant is doing kind of the majority of the work in pedo? And the hygienist comes in to scale and make sure that everything looks okay, like realistically, and taking into consideration that usually pedo hygiene appointments are like 30 minutes or less sometimes. So like in a certain time, in a 30-minute time frame, how many patients can they actually see?
Yeah, so I would have to default the detail of that answer to Malika just because I don't have a lot of experience in pedo. And I could see where it would kind of get away from you pretty quickly if you are like, oh, we can see one patient every 30 minutes out of 2 columns. Like, that's a lot of patients. So I don't know that I'm qualified to answer what that top limit would be in there. I don't know, Malika, do you have some thoughts on
I
that?
mean, it's funny. I have an office right now that is doing assisted hygiene pedo practice, very busy pedo practice. 2 hygienists, 2 assistants, so 4 columns total. It
Okay.
is every 30 minutes, but
Yeah.
between the every 30 is
Staggered.
it's scattered. And the
Okay.
second column is 40.
Okay.
Okay.
Yep.
And obviously there's a lot of sealants that are happening in pedo hygiene.
Yep.
So very, very, very profitable. And as Michelle said, you have to have a special personality for that kind of hygiene. Like
You do.
that is like on another level, but it works. And I'm sure, like, not to kind of go off topic, but there's states that, like in the state of Virginia, you don't need a hygienist. So that's a different conversation where the assistants are doing the polishing. The doctor comes in, and if there's any scaling that needs to be done, does it. But that's like every 30 minutes straight down. And you can have 4 assistants doing this across the board. So I have clients that tell me, like, I don't want to open in a state where I have to have a hygienist because it's not as profitable for me. So
Interesting.
for a pedo, it's interesting. When I'm in the DMV area, which is,
Yeah.
Virginia, Maryland, DC, Virginia is the only place that you can do without a
Really?
hygienist.
That's
And
interesting.
yeah, so a lot of my clients will say, well, I live in Maryland, but I'm going to open in Virginia because I don't need a hygienist. And with the
That's
hygiene,
interesting.
yeah,
Because in North Carolina, where I am, which is a very dental conservative state. Like, we just got local anesthetic 3 years ago, maybe.
yeah,
But dental assistants have been able to take a coronal polishing course for, oh my God, I'm going to say, probably 15 or 20 years, if not more than that. So I would say that's really, as long as they're x-ray certified
yeah,
and they have coronal polishing
yeah,
and the dentist is willing to do scaling,
right.
then that could absolutely work. Yeah, I kind of assumed that most states had that
No, like
option for
Maryland's
dental
very
assistants.
strict about this,
Interesting.
and
Okay.
DC. Now
Okay.
Texas is not, Virginia
Yeah.
is not. North Carolina. Some states are super low key, like, and that's why here pediatric dentists tell me when they're looking to open and practice within certain mile,
Hmm.
if
Yeah.
you can drive to it, they're like, I'm going to open, for example, in Virginia because it's going to be easier
Do
for me to,
more.
like, and it makes
Well,
sense in some ways.
yeah. And that's something to consider with assisted hygiene as well. Now, not that it can't be productive if the assistant can't do polishing, but that certainly is just another piece, another thing that can be delegated. Now, I will say, with I'm going to call it a trend, and I don't mean that it's trendy and it's going to go away, but like I would say new innovation. How about that? With guided biofilm therapy and the use of subgingival glycine powder polishing, that will take the place of coronal polishing.
Mm,
So if it's a practice that's using that, then the assistant would not be doing that subgingival polishing, right? That would need to be a hygienist. So that would be something to consider, but doesn't mean it can't be done. It's just one more piece. And maybe they do coronal polishing on, patients that are less than a certain age, and then the hygienist does the subgingival polishing on all the other patients, and they kind of work it out that way. But so many different ways to work this out, and I think that's where having some type of framework is really helpful for the practices, and then they can tailor it to their allowing their providers to work at the top of their license, because that really is the goal. And I will tell you again, having been in a lot of different practices in all over the country, it's very rare to see hygienists who are truly working at the top of their license, who are really doing everything that they are legally capable of doing on a consistent basis. That's the key, is like, well, yes, I can use lasers, but I only do that once every quarter on a patient that has this particular case, So building the standard of care also to maximize that, those allowable duties, and the scheduling model to maximize those allowable duties, I think really can help the hygiene department be profitable, even at the high wages that so many areas are seeing now.
And I think it also depends, I'm sure you see this more than, I do, is the type of practice. There's practices depending on the location, younger crowds, they're close to a college or, depending on where they are, or the areas where I have a practice where a majority of patients are over 60. So very heavy in perio, and when they're looking for hygienists, they want to make sure the hygienist is comfortable with perio because it's very heavy in perio. So it's very interesting to see that difference. Where I have a practice where the average age is 20, and
Wow.
it's like interesting to see the mix of the two. And I've spoken to hygienists where like I prefer to be with the practices with the older patients. It's like almost like the whole hospital mindset of
Yeah.
where you end up doing, what you do, which is kind of interesting.
Yeah. It's very interesting. Yes. And determining what are the services that cater to that patient
Yeah.
population. And I would still, I mean, I can't do a podcast without saying this on this topic is, I would still, even if they have a young population, have a really clear standard of care.
Yes.
And have a really clear understanding with the team on when do they cross the line into where they're no longer a healthy adult prophy and they need some type of alternative care. Don't just assume that because your average age is 20 that nobody has periodontal disease.
Right.
Yeah.
And I tell those offices too to focus, because I have the same as Malika. A lot of the startups are attracting the younger patient population, and their perio percent is like in the teens.
Mm-hmm.
But I've kind of looked at things and I'm like, okay, like this is what you have. So I say, like, we're not going to focus on the percent of your perio patients, but we're going to focus on the percent of perio accepted. So
Yeah.
are you doing a good job when you actually are finding and diagnosing it? Are they following through?
Yeah, good point. Good
Yeah.
point. For sure. Are you encountering practices that have decided to not hire hygienists? I would say, aside from this pedo example, not hire hygienists. And then is the dentist doing all the hygiene? And what are you encountering there?
I've seen a few. I don't know about you, Malika, but I do. And it's a little bit challenging because I have maybe a handful of doctors who actually like doing the hygiene component.
Okay. Yeah.
And most of them are like, oh my gosh, I'm just doing it because I have to, and I can't find someone. I personally have found maybe they skip a few steps.
Yeah. Yes.
Especially in the new patient exam.
Yeah.
And I feel like that's one of the most important to get yourself established with them. So I would love if you could talk a little bit on what are even the minimum expectations of a dentist that's doing hygiene.
Yeah, I've seen that too. And the dentists that we work with will admit that. They'll say, well, that, we have our hygienists. That's why the new patients go through hygiene, or that's why I do the new patient visit, as the doctor is saying this, and I have the hygienist come in and they do the complete perio charting. So I would say that's coming from a hygienist, that's the minimum, is doing a complete periodontal charting. You have an assistant right there. So you can utilize your assistant, or if you have a voice activated system, right, that we recommend those, to utilize that, but to really do that complete periodontal charting. Because if you're going to, it's just like what we would expect a hygienist to do. So that is the minimum. The patient is coming to you for a complete evaluation of their oral health. And if they don't have a complete periodontal charting, which includes pocket depth, bleeding, furcation, recession, mobility, pus, if those things are not recorded, then there's not evidence, there's not the full scope of evidence of the disease. So then if you recommend that they go into scaling and root planing, then you're not going to have the documentation to back up to get reimbursement for that.
Right.
So it's going to cause problems later. You're going to get denials and things like that if you're not collecting that complete diagnostic information. I would say that, along with some radiographs of diagnostic quality, having that complete periodontal charting is critical. So that's the thing, is if you're not going to have a hygienist, are you willing to do not only the scaling piece, but the diagnostic piece of what that entails?
Which is huge.
Yeah.
It is huge.
Huge. And what I see a lot is when I'll go into a new practice, just looking at it, I run a report of the top ADA codes. You don't know how many offices don't do FMXs.
Yeah.
And I'm just they're like, well, PAN is quicker. It's a lot easier I'm like, do you know liability wise?
I'll do a PAN and 4 bite wings and a couple PAs.
Yeah. So it's like,
Well,
with these insurances too, I'm sure Rachel, it's like, they're not going to pay for anything if you don't have an FMX these days. So
right,
to skip
right.
that part, and it's like same price as pan when the insurance company pays for it, do it the right way and take the time to do it, because it's necessary.
It is necessary. And I will tell you, there was a time where there was one particular manufacturer, who I will not name, who was educating clients, and I think it was part of the sales process, was educating dental teams that if you use this technology, which was, I'm going to say like a pan, maybe borderline CBCT, that you do not need to take bite wings. And that you can bill out for bite wings using this technology. And I said, you guys be careful, because the code on a bite wing says that it is an intraoral radiograph and you're taking an extraoral radiograph. Well, so-and-so manufacturer said we could do this. I was like, well, they're not the ones that are going to have to be answering to the insurance companies and reimbursing, paying back money that has been paid to you for these radiographs if you ever get audited. And they're just not the same quality either.
No.
So it is. And periodontal charting is extremely tedious, and dentists typically do not like to do that. They don't want to do that. They'll do a bit of spot probing and then kind of make a general recommendation, which is totally fine if you have a hygienist that's going to follow it up, right, with a complete perio charting, and you have a standard of care that if you even see a sign of periodontal disease, you're getting them to the hygienist for that, and then they can, determine the full extent, and you can work together to create that detailed treatment plan. But yeah, if you're the dentist that's doing it all, I would urge you to do a complete periodontal charting. Yes.
Yeah. And back to the FMX and Pano thing, I tell my doctors, if you need to take both, take both. Right? It's not like we're in the old days when we all started in dentistry and we had the film that we had to develop, right? Yes. It's costing you extra for film. You've already got the equipment there. Right. It's 10 extra minutes to take an FMX, if that.
Yeah.
And now it could also help increase the treatment planning method, because you've got two different views of it. So to me, it's worth it to take both, charge for one of them. If you want to charge the patient for the second one, that's their choice. But to me, buy one, get one free in this point.
Yeah, that's typically our recommendation as well. And also if the practice has any type of AI radiograph, it's going to be able to spot things or help you spot things on the FMX if you have that, that information. So yeah, I think that the no hygiene model, certainly I'm sure that there are ways that it can work. I would never stand here and say that could never work, because that's just, I think, a closed-minded, approach to things. I just think that there are some really clear systems that need to be in place, just like they do when you have a hygiene team. And I do think that I would just imagine that it would become limiting from the doctor's ability to do restorative care and manage a growing practice with a growing number of hygiene patients. I would just imagine that would be very difficult to allow that to continue, to see that continue to grow.
So can I ask a question, slightly off topic, but I feel like it rolls in a little bit, is, there's all these statistics and benchmarks out there. How many patients, do you feel that a full-time hygienist can support?
Great question. So we say anywhere between 600 and 800 patients. Now, 800 would be if they're there 4 days a week and they're seeing one patient every hour, twice a year. Okay. Now, the 600 is more realistic because they're going to have new patients likely that come and spend more than an hour. They're going to have scaling root planning patients that come in and spend more than an hour. They're going to have patients on periodontal. If it's a real heavy perio practice, even a GP practice that has a heavy perio focus in hygiene, then they're going to be able to see fewer patients because they're coming more frequently. But that is kind of a general rule. I would say it's probably more like 600 to 700 patients in recare 2 to 3 times a year per 4-day-a-week hygienist.
Yeah, and that's exactly what I am telling people too. So I'm happy to hear we're on the same page.
Me too. Happy to hear that lines up. Yeah. Yeah.
Okay, and then I guess I have one last question for you. If somebody is looking to implement this, whether it be the assisted hygiene module or the doctor implementing a little bit more to what they're currently doing before they just say like, okay, tomorrow this is how we're going to do things. What is your recommendation for planning it out and, making sure it is going to be a success?
So I would say sit down with the team and just discuss what your vision and your goals are for this initiative. So if this is something that you're going to add, whether it is assisted hygiene, whether it is a more refined periodontal protocol, whether it is adding an adjunct service, right? Sit down and really define with the team, what is our goal, ultimate goal for this, for the patients, for the providers, and for the practice. And then how can we work together to make this successful, and what information do we need to have to make this successful? There are so many resources out there. Even on Inspired Hygiene website, we've got it says resource guide on our website. We've got a ton of free resources there, including a standard of care worksheet. And I really believe that before we launch into things, it's important to know, like, okay, what are our standards? Because we don't want to compromise our clinical standards of care for a scheduling model. So let's make sure we're all on the same page with that. I would say implementing one major thing at a time is a good idea. So I wouldn't necessarily say like completely revamp your perio protocol and implement assisted hygiene at the same time. Like pick one, figure out which one needs to be in place first to support the other. Right? So if you can't get any patients in for scaling root planning, then probably expanding your scheduling options is going to be the first thing to address. And then you can go to the next step. But I would always just say, work together as a team and collaborate on it. When the practice owner or practice leader kind of comes up with the plan in their office and is like, here's what we're going to do. That's when a lot of times there's resistance. I think when we have a conversation of, here are our goals, like we're responsible for caring for these patients that are depending on us, and we're doing everything we can to find a hygienist. We're just not there. It's time to try something different. And I really believe there's a quality way that we can implement this. And, you have my word that we're going to maintain the standard of care that we've been delivering. Can I just ask you all to just open your minds that this might be a possible solution and have that type of conversation, collaborate, find an outside resource, whether it's one of you as a coach or consultant, because you all have this experience that comes from seeing things being done over and over and over and what the typical obstacles and opportunities are. That's always very, very valuable, so that the team has a guide. I mean, when you work with a coach, you can leapfrog over a lot of those kind of false starts that you would have if you're doing it on your own, right? Every coach or consultant should come with some systems that they have seen work time and time again that they can help you implement, that's going to help you just get it there faster than you're doing on your own. So I think that's a critical piece of implementing anything new as well.
Well, thank you so much,
good.
Rachel. I learned a lot too today. So don't forget to check the show notes for the information on Rachel's assisted hygiene bootcamp and any links to her website or additional information. And really, if you found this episode helpful, like share it with your colleagues, because I'm sure they have questions too, and could benefit from listening to some of Rachel's advice.
Yes, thank you so much for the opportunity to be with you both.
Thank you.
And hopefully we can do it again sometime. Thank you again.
Absolutely. Thank you.
Thanks for joining us on Accelerating Your Dental Practice. To connect with Malika and Michelle, visit czardentalconsulting.com and affinitymanagement.co and learn how they can help you accelerate your practice even further.